Hello, Dr. Borgi, and hello, Karen. How are you today?
Good, thank you.
I'm very good. Thank you, Joe.
Dr. Borgi, could you tell us a little bit about yourself, your background, and your career, please?
For sure. So I'm Dr. Leah Borgi. I initially did medical school back in the Middle East in Lebanon. And then I came to the United States about 12 years ago. I started in research at the Brigham in the Transplantation Research Center, already excited about kidneys. Then I did my internal medicine specialty and I came back to subspecialize. So I subspecialty in kidney medicine at the Brigham and Women and Mass General. It's a joint program. And now I am a kidney doctor in the community, and I have interest in research specifically in nutrition and the association of nutrition and chronic diseases such as kidney disease.
And Karen O'Neill, nurse practitioner. Tell us a little bit about yourself, your background, and your present role.
So my career started in nursing. Actually, come full circle. I started as a nurse at Peterborough Brigham Hospital School of Nursing 42 years ago. So that's a long time ago. It was my first experience in nursing, and my first job was actually working on a renal cardiovascular floor. So as a evening charge nurse. So right from the start, I've been interested and exposed to nephrology and kidney patients, and I've always had a fondness for it right from the start. Since then, I moved on to baccalaureate program at Emmanuel College in Boston, and then on to UMass Boston for graduate school as a nurse practitioner. And throughout my whole long career, most of the time has been spent in nephrology nursing. Surprisingly, I've worked a lot in the acute care hospital settings in Boston, working in floors where taking care of patients with kidney disease, as well as kidney transplantation. Moved into dialysis as in the hospital setting, as well as dialysis in the outpatient setting. So spend a lot of time in the advanced kidney disease programs, and started a home dialysis program where I spent 15 years helping patients learn to live well at home with dialysis. For the past 4 years, I've come full circle now. I'm back to the Brigham Health and Brigham at Harbor Medical in the renal outpatient program with Leah Borgi, working for the Brigham and the outpatient clinic. So my focus really to become a nurse practitioner was to really take my nursing to another level, to help really advance, help really focus on education. As I saw so many years of working with patients with dialysis and transplant, there needed to be some education in the chronic kidney disease world. So that's where I've been really focusing on I see my role as education and support to empower patients to live with kidney disease well. And we try to do that in a positive way in our program.
So what exactly is nephrology? Dr. Borgi.
Yeah, so nephrology is the taking care of kidneys, basically. It's also called renal medicine. And any type of kidney disease, nephrologists are going to take care of it. The kidneys are essential organs in the body that they clean the blood. So they remove toxin and they remove the waste into the urine. So nephrology is a specialty that takes care of your kidneys.
And when we look at kidney disease, and Karen, if you could address this, when does a person need to be seen by a nephrologist?
Well, the thing with kidney disease is really people don't have symptoms in the very early stages. So unfortunately, oftentimes patients aren't referred to nephrologists until they're sort of at advanced kidney disease. Ideally, it would be around stage 3 kidney disease. But when patients start noticing symptoms, it's usually more advanced. So the patients we see sometimes, if they're referred from primary care settings, then that's great early on. I think sometimes people could do a little bit more helping their disease process if they knew early on that they had some kidney disease. So,
but a patient can be referred to a kidney doctor if they have any acute kidney problem, meaning,
Correct.
and this is measured by a blood draw. So if there's an abnormal function of the kidneys, this is when a kidney doctor will see them. And sometimes if there's consistent blood or protein in the urine, then a kidney doctor will also be able to help. If there are very resistant high blood pressure, which is extremely common in the United States, and when the diabetes is affecting the kidneys, which again is common here in the US, then this is when the kidney doctor will come in and become a part of the patient's team. And this is what I sort of tell the patient. We are all here one team, but I will be the doctor, myself and Karen, we will be the kidney police, right? We'll always monitor the kidneys, and our aim is for your kidneys to stay exactly how they're functioning and not progress into advanced kidney disease.
Now, when we talk about kidney function, and let's just focus for a moment on the fact that we are in the hopeful last stages of a pandemic, a year-long period where many of our people have been homebound, have not had an opportunity to see their primary care, particularly around annual physicals, as an example. So in layman's terms, what are some signs, symptoms of early stage, mid-stage kidney disease?
Yeah, so I think I'll start with the early stage, and then Karen you'll go over the late stage. So as Karen actually explained, it's sometimes I tell patients it's fortunate and unfortunate, depending on how they see it, that there are no symptoms or signs of early kidney disease. So if there is, because we have two kidneys, usually this is why we can donate a kidney. The body can function with one kidney, and most of the time, patients don't have symptoms till the kidneys are working at about 25%. But if they're working anywhere between 30 and 60%, which is really chronic kidney disease stage 3, and it's the most common stage in the US, most patients are in that stage, then they don't really have symptoms. It's really a blood result that we see. And this is why during the pandemic, we made sure to sort of tell patients if something worsens, right? If you start having symptoms, if your blood pressure increases, if you're starting seeing a lot of bubbles, like foam in your urine, let us know. But throughout the year, we would like you to check your kidney function at least once during that pandemic. And we really made sure to have our patient have a blood draw at least once to make sure that the kidney disease is not progressing.
Karen, would you like to add to that?
Yeah, and I think we were fortunate here that we do have a homebound draw program, so that we were able to, if patients couldn't come out, nor did they want to come to the clinic for labs, we could send the lab to them, and they felt, safe with that. So that's correct. As Dr. Borgi said, the earliest stages, there really aren't any symptoms. As people progress in their kidney disease, the symptoms become sort of vague, but they're when we put them all together, they're signs of the kidney disease where people become more fatigued. That's probably the most common symptom, fatigue, which progresses and gets worse. Appetite changes. Sometimes people will complain of a metallic taste in their mouth, food, aversions to certain things. They may, even though they're very tired and fatigued, they have difficulty sleeping. Sometimes people will find itching. Their skin becomes very dry with the buildup of the waste in their blood under their skin. They become very itchy and have many symptoms like that. Sometimes people will notice swelling. They're retaining fluid from the kidneys not working so well. They may become short of breath at more advanced stages. So as the kidneys functions decline, the symptoms become more.
What role does gender and diet and genetics play in kidney disease? Dr. Borgi.
Yeah, so I think gender, the risks of having kidney disease are almost, about the same in men and women. Diet, like anything in our health, right? Like the risk of high blood pressure, the risk of diabetes. If you are having a sedentary life with mostly a diet high in fast food, processed food, saturated fat, so anything, sodas, sugar, refined sugar, all of that will not only increase your risk of kidney disease, but it will also increase your risk of having kidney disease progress to these end stages, where you'll need that, where the kidneys will completely stop functioning. And this is why whenever I talk to a patient about diet in kidney disease, we do have specific restrictions, but these restrictions are mostly for advanced kidney disease if they have to restrict high potassium foods. And it's all based on the blood work. Otherwise, what I like to tell them is try to increase plant-based protein, fruits, vegetable, have a variety of food that you're eating, and try to limit the processed food, red meat as well, because that will help your blood pressure. And if you have diabetes, it will help your diabetes, and as well, it will help your kidney function. In terms of genetics, there are specific diseases of the kidney that are genetically inherited, but they're not, it's not that they're not very common. The most common one is called polycystic kidney disease. And if someone in your family has this, then you will know, because usually it doesn't jump a generation, it's from generation to generation. And that person will be referred to a kidney doctor quite early on, even as an adolescent. There are other forms of kidney disease that we see as well in our clinic that are genetic.
So it stands to reason that when you're sitting down with your physician, as much as you know about your family history, if you would just say, my mother or my father or my brother or some other immediate family member having had to go for dialysis, that might be a connecting point to what you refer to as polycystic kidney predisposition?
Yes, usually kidney disease. So we do ask the question, does anyone in your family have a history of kidney disease? And depending on the answer, so if someone says, well, my father, when he was 80, his kidneys failed because he had diabetes, then this is more related to the diabetes effect of the kidneys. But when the answer is, well, actually, yes, my sister needed a kidney transplant when she was 40 years old, then this is where, we start thinking, is there a genetic component to the kidney disease? And something like polycystic kidney disease comes in and can be diagnosed by an ultrasound of the kidneys.
Karen, you had mentioned earlier about getting dialysis either in hospital, outpatient, even at home based. Could you tell us a little bit more about the different levels of treatment there?
Sure. So when people get to the stage, and thankfully only a small percentage of patients really get to end-stage kidney disease where their kidneys completely fail and need a renal replacement therapy. So that's the good news. But there are, despite the best efforts, there are patients that obviously do progress in their kidney disease. And so what we do in our clinic is try to help patients choose the best treatment for their lifestyle, based on their family, based on themselves. So try to make it an effort with the patient as well as with the providers to teach them about that. So, most patients will find that when they get to that stage, having either a kidney transplant or dialysis at home really offers the best quality of life. However, not everybody is eligible for a kidney transplant or could do dialysis at home. So we also have dialysis in the outpatient local clinics that patients can manage on an outpatient basis and receive treatment in the clinic with the dialysis team. So when kidneys are no longer able to clear the waste or remove the extra fluid and people become very symptomatic, then we start talking about the renal replacement. Home therapy versus in-center therapy versus kidney transplantation. We also have, for some patients who maybe have many comorbidities besides their kidney disease, we also have medical management for people that we don't feel that dialysis would really improve their quality of life. And those are usually older patients with many other health issues too. So we kind of individualize it to the patient and to the family and really work with them to educate them to see what would be best treatment for them. And sometimes my experience has been many patients throughout their lives go through all of these treatments at one point or another. So doing one doesn't mean you can't switch to another. And many times people go through the whole circuit through the course of their lives.
What are kidney stones? And I hear people talk about passing a stone. And does one always have to pass a stone, or can you dissolve it miraculously some way?
Yeah, so kidney stones, they're always interestingly by men compared as giving birth. And I never fully understand how they would know how to compare that, but they're extremely painful, unfortunately. And every time someone has a kidney stone, then they have to go to the emergency department because it's so painful for medication. So kidney stones, there are some diseases that put you at a higher risk of kidney stones. And the most common one is calcium oxalate. So it's really the precipitation of calcium and oxalate into your kidneys. Okay. Now, when someone goes to the emergency department, this is where the urologist is coming in and trying to remove or break through a laser going into the kidney, break that stone. And this is when the stone is being passed. Okay, so this is a bit of an anatomy one-on-one. So you have the kidneys and two tubes that come into the bladder. If the stone is being broken into the kidney, then it can get stuck. When it goes into this tube, it's extremely painful because it's hitting the walls of the tube, and then it goes into the urine. So they're actually passing a stone. And a lot of time patients would bring us the kidney stone. Now, yes, and some of them frame it, which I've heard about that, but I haven't seen that. Now, the urologist is very helpful in trying to sort of address the acute treatment of kidney stone, but also the kidney doctor or us, the nephrologist, would look at the causes, right? Can diet modification help? Eating less oxalate food? Can a medication help? So basically what kidney doctors do for kidney stones is try to prevent the formation of new kidney stones or prevent these small, very tiny stones from expanding and becoming very, very painful. Usually when I ask patients, do you have a history of kidney stones? It's never, we don't know. If it's a yes, it's a very strong yes, because if they pass the stone, they will never forget that.
Let's talk about COVID and the impact of COVID as it relates to a patient who has kidney disease. Dr. Borgi.
Yeah, so patients who have kidney disease are at higher risk of getting the infection because it is a significant comorbidities. It's like high blood pressure and diabetes. So we did make sure to tell our patient that they need to be extra careful during COVID, like everyone else, but specifically because they have comorbidities. And also what we have seen in the hospitals is patients without a history of kidney disease or patients with a history of kidney disease, COVID, the virus itself was unfortunately affecting the kidneys. So if you have kidney disease and you have and you got the virus, then there was a chance. We have seen that the kidney function worsened because of the virus. And in people who were healthy, who got COVID but were quite sick in the intensive care unit, then it also affected their kidney function, even though they did not have a history of kidney disease. So we really, really stressed on the importance of, initially social distancing and wearing the mask, and now on the importance of getting vaccinated.
And so does getting vaccinated affect your kidney disease? I mean, are you aggravating your disease as a result of getting a vaccination? Is it safe to get a vaccination?
It is safe to get a vaccination. It is highly recommended. And we do, every time I see my patient in kidney clinic, I ask them, and thankfully most of them have received. And if they have not, we help them get the appointment, because the vaccine itself is not going to affect the kidneys, but the infection will. It has it's not 100%, but it has a high risk of affecting your kidney function.
I agree as well. I also work in dialysis clinic too, and we have also seen a new group of people with kidney disease, basically from the virus. That would probably not have had kidney disease before. So that's another reason to really focus on the importance of the vaccination for all of us, in general, and particularly in the kidney disease population, because most of the patients with kidney disease also have other comorbidities of heart disease, diabetes, and other things. So they're really probably one of the higher risk groups to get COVID.
You go through your annual physical, they look at your blood work, they look at your urine work, and then it comes back and there's this conversation that says, you need to see a kidney specialist. And then there's this fear that takes place. Why is that? And how do you respond to patients who come to see you, knowing they're coming through the door, afraid of what they're going to hear and afraid of coming in contact with, let's say, dialysis? Karen, would you like to talk to that first?
Yeah, I think that is scary for them because they're not exactly sure, and usually they're not really told too much details that we just think you should see a kidney specialist. And a lot of people will just come with that information. They really have no other idea. So we're, really try to be reassuring and say that, it was probably a finding from your blood test. There might have been some blood or some protein in the urine, which is, especially for people with diabetes, is very common. And so we try to reassure them that, yes, this is a sign of some early kidney disease, but we're going to work with you to help slow the progression of this, through further workup or evaluation. And Dr. Borgi is very good about helping people, allay their fears on that, because it is stressful. It really is. When you hear that kidney disease, people really aren't sure what that means. And exactly, people have always heard some horror stories about dialysis. So we really try to comfort them that they're nowhere near dialysis. You have some very minor changes, very mild kidney disease, and that's what we're here for. We're here to help you, and we're here to protect your kidneys.
Yeah, I think Karen and I really, I think we work very well together in trying to tell patients we are on your side, right? We don't want your kidneys to progress for you to get to dialysis. And if that happens, and a lot of time I do ask them about their experience. Sometimes it's a relative, it's a friend who was on dialysis. And I sort of try to tease out what was problematic about your friend being on dialysis, and ask the patient, what do you enjoy doing? Right? Is it, do you enjoy, are you running marathon, right? Because probably if you're on dialysis, it probably won't be feasible if your kidneys completely failed. But if you enjoy seeing your grandkids and watching TV and just having, or reading a book or even traveling, then dialysis will give you this quality of life. So even when patient comes in and they are in need, probably in the next 6 months or a year of dialysis, I think we need to tell them we are here with you. Well, we are not going through it, but we have patients. We can connect you with patients who have gone through the same, the same experience, because it is a unique experience, and we will help you throughout your decision. But most of the time, like Karen said, when they walk in the door, especially my elderly patient at 80 or 82 years old, and they're like, I heard I have kidney disease, am I going to end up on dialysis? And I'm like, you have extremely mild kidney disease, and I'm here, I will be the one looking at your numbers, and I am not worried about your kidney disease, so I don't want you to worry about it. And I think just the words, right? Because it just reassures them, and they know they have someone. If they have a question about the medication, if something is hurtful for the kidneys, then I always tell them, you reach out to us and we will protect your kidneys no matter what.
Dr. Borgi, Karen O'Neill, nurse practitioner, specialists in nephrology. Is there anything else that you can think of that you want to share with our viewers?
I think, I also get a question a lot that, what did I do so that made me have kidney disease? There's a lot of guilt when it comes to our health, unfortunately. And I think this is always important. And I always try to reassure patients that you are doing everything you can, right? So I will tell you, you have to control your blood pressure. You're doing that. You're controlling your diabetes. You're doing that. But sometimes, unfortunately, like our body ages, our kidney age as well. So I try to reassure patients that it's not their fault they have kidney disease. And I think this is something usually in medicine in general that is, patients feel extremely guilty about their diseases. So I think I just wanted to stress that.
And I like to just, encourage patients to, empower them to learn as much as they can about their kidney disease, take charge of it, learn about their blood tests. When they come armed with questions and they know about their blood tests, then that's important. They're being part of it. They want to learn about how they can slow it down themselves, how they can improve with exercise, with diet, with medications, with, increasing their fluid intake and just some basic things, smoking cessation, things that are, very healthy. Those are things that are also healthy for the kidneys, stress reduction. So I try to work on, the educational piece of helping them just, live well with their kidney disease.
Dr. Borgi and Karen O'Neill, nurse practitioner, I want to thank you both very much for taking time with us to talk about the area of nephrology, kidney disease. We hope our viewers really appreciate all that you've had to share, and we look forward to visiting with you again real soon.
Thank you for having us.
Thank you for having us, Joe.